Hello, I'm John Hick, emergency physician at Hennepin County Medical Center, here today to talk to you a little bit about crisis standards of care and pediatrics. After viewing this module, you should be able to understand the concept of crisis standards of care and when they might be utilized. You should also be able to summarize the exclusive pediatric issues that may be present during a surge of pediatric patients that could necessitate a change in standards of care. Finally, you would know where to access the Minnesota Department of Health Crisis Standards of Care Framework on the Internet. During a disaster, there may be limitations in supplies, equipment, or staffing. These limitations can result in necessary adjustments to the standard of care for patients. This adjustment changes standard care to crisis care, where we shift to doing the best we can for the greatest number of patients. Crisis standards are when the state or other agencies formalize the changes needed to support a long-term medical response by promoting consistency and invoking regulatory changes and declarations. For example, emergency declarations can trigger changes that improve provider protections or enable cross-border licensure recognition. We attempt to maintain the standard of care for as long as possible, adjusting the treatments to conserve supplies in shortage. In a disaster, there may be progression from conventional care, usual resources, through contingency care, adapted resources but providing the same functional care. For example, providing intensive care in a post-anesthesia unit, and into crisis standards of care, where we are unable to maintain equivalent care and must try to balance the needs of all the patients, which results in some risks of a poor outcome for some of the patients. For example, treating asthmatics with nebulizers using hospital oxygen to aerosolize the medication is standard care. If oxygen is in short supply, using pressurized air, and then, if that is not available, using inhalers for delivery of the medication would be contingency care. Deciding to reduce doses or withhold medications from some patients would be crisis care. To view the Minnesota Department of Health Crisis Standards of Care Framework, go to the website listed here. Let's talk about pediatric-specific issues in crisis standards of care. There are few pediatric hospitals in the state, and if there were a lot of pediatric victims, there would be a shortage of beds. Injured children younger than 8 years old, or those with complex congenital or medical conditions, would preferentially be sent to pediatric hospitals. Because of this, general medicine care units must be prepared to care for pediatric patients who are not critically ill. Patients who cannot be transferred due to weather or transport capacity issues need to be stabilized and stay at non-pediatric hospitals until transfers to pediatric hospitals are possible, with the assistance of expert advice via telemedicine or telephone. As part of the Minnesota Pediatric Surge Plan, Level 3 transfers to neighboring states' pediatric hospitals would be implemented. Hospitals should be prepared to care for patients of all ages by having the appropriate equipment to use during a disaster. The American Academy of Pediatrics and the American College of Emergency Physicians have a list of the equipment advised for all emergency departments. These lists can be found at the website listed here. There is a similar list in the Minnesota Pediatric Primer, which can be found on the Minnesota Department of Health website. Flexibility during a crisis is key, and prioritizing the use of equipment and medications according to the size and age of the patient is important for conserving supplies. A checklist and guidelines for care of children can also be found on the American Academy of Pediatrics website. Peds Ready, a program with EMSC and the AAP, has a toolkit that will help evaluate emergency departments' readiness for a sick or injured child. Here is the website for that toolkit. Adequately trained pediatric staff may be at a premium during crisis situations. Hotlines to pediatric experts, just-in-time teaching, and telemedicine can help with the stabilization and treatment of severely injured pediatric patients. As we all know, children require more attention and supervision than adults. Recognizing these needs and supplying psychological support and providing a secure environment is important. Identification can be an issue with very young children. Tracking the unidentified minors, providing supervision for unaccompanied minors, and family reunification processes are major concerns that should be planned for by all hospitals. Assigning caregivers to monitor and occupy the minimally and non-injured children is important. The pediatric primer on the MDH website lists the number of monitors needed to supervise young children by their age group. Patients with autism and other conditions may require calm monitors and holding areas that are quiet and non-threatening. Please refer to the module on children with special healthcare needs for advice on these populations of children. The unique characteristics of sick and injured pediatric patients are dealt with in the trauma and non-trauma modules of this series. Remember, a child's physiological status can change quickly. Children can decompensate fast. However, they improve quickly when treated appropriately. Therefore, frequent reassessment of children is paramount and is easily forgotten during a mass casualty incident. Transporting the critically sick and injured to appropriate facilities improves the recovery of children. When many families are impacted, trying to keep the families together is important. Therefore, during a disaster, pediatric facilities will need to care for injured adults, and non-pediatric facilities will need to care for children. The sickest patient in the family should drive the choice of destination. During the initial time of crisis, older family members can monitor their children, freeing caregivers to treat more victims. Involve behavioral health professionals early in the crisis to help calm the patients and reduce anxiety. The next 4 slides show what information is available from MDH for pediatric crisis standards of care. This is the pediatric triage card for mass casualty situations. It can be found on the MDH website. It has information that will help you evaluate a surge of pediatric patients. The orange box has advice on which pediatric patient should be a high priority for transfer to a pediatric facility. As part of the previous card, this blue box lists the initial interventions specific to children. This is the Pediatric Assessment Triangle, an easy method for determining which children are sick and which are stable. By a quick glance at the patient's appearance, breathing, and color, you can determine if emergency intervention is needed. In conclusion, this module should make you aware of the pediatric aspects of crisis standards of care and the unique characteristics to be aware of when dealing with children in a time of crisis.